From the get-go, we reached out to JOSPT, APTA, AOPT, and we wanted this to be a clinical practice guideline that would be endorsed, that would be supported by these entities. And, JOSPT has, this format that's already existing in terms of the level of obligation. And that's pretty much what we used, which is, it's a very straightforward way of wording recommendation and the level of obligation to that. So we based it on that.
Welcome to the Did You Know podcast, where we explore issues in physical therapy research, clinical practice, and leadership. Today, we're digging into a new clinical practice guideline on rotator cuff tendinopathy.
Right.
My name is Brody, and I am a physical therapist at the University of Wisconsin Hospital Science Drive Medical Center and a professor at Rocky Mountain University of Health Professions. I'm also board certified in sports, and I'm here with my younger sister. Go.
Yes, she had to say it because I would if she didn't. So, hi everyone, my name is Jill Thein-Nissenbaum, and I'm a professor at the University of Wisconsin-Madison, where I teach in the physical therapy program there. I teach the orthopedics courses, I teach a sports PT elective, my clinical practice is with UW Athletics, and I'm also board certified in sports, and I am, as I'm going to emphasize again, the younger sister.
So we're here to discuss these new 2025 rotator cuff tendinopathy guidelines.
Right.
And you may ask yourself, why do we have a new set of guidelines when there was just a set of guidelines that came out in 2022?
Right.
And it reminds me, Jill, of when you cleaned out your closet and you took a bunch of your clothes to a resale shop.
I did.
And they did not take them because they said they were out of date. And what did you reply?
I just wore them last week. How could they be out of date?
Exactly. So for those clinicians who just got the new 2022 guidelines uploaded into their templates at work and just passed them off to their referring providers saying, here's how we treat rotator cuff tendinopathy. We're gonna dig into why we have some new ones. And to do that, we are blessed to have two of the authors of this paper. First is Dr. Francois Desmeules, and I am introducing him because I had 2 years of high school French. So he is currently a full professor in the School of Rehabilitation at the University of Montreal in Canada, where he's the head of the Advanced Practice Physical Therapy program and teaches evidence-based practice, health services organization, and musculoskeletal physical therapy. He's involved in like a bajillion different things, and you can Google him, and I would tell you where he conducts his research, but I can't pronounce it because it's French.
It's great.
So we're pleased to have you with us, and he has graciously allowed us to refer to him as Francois, so I didn't have to pronounce his last name a million times. Thank you, Francois, for being here.
Thanks for the invitation. So that's a great invitation. So I'm happy to be here to talk about the CPG for sure. Thanks.
Thank you. And also with us is Lori Michener, who is a PT, PhD, and a fellow, both within the APTA and the NATA. And she is a professor and the director of the core laboratory in the Division of Biokinesiology and Physical Therapy at the University of Southern California in Los Angeles. And the central theme of her funded research is to define patient-specific mechanistic factors related to the development and persistence of shoulder pain and elbow pain, specifically in the athlete. And that brings an interesting twist with Lori's research because there are return to sport guidelines in this CPG, which didn't exist in the last CPG. So Lori, as an author of the CPGs as well, we're delighted to have you. Thanks for hanging out with us today.
Great. Thanks for the invitation.
So, we're wondering why we did this. Like, why was it important to create a new CPG literally 3 years after the last one was published? Is there a different audience? Do we have new data? Does it include different audiences and our populations? Can you expand on that for us? The why?
Yeah. So I guess starting from a decade ago, we started working on recommendation and evidence synthesis for shoulder pain, more in particular rotator cuff tendinopathy, and also rotator cuff full thickness stare. So one of the lead co-author is not here today, so that's Jean-Sébastien Roy, and we were working on this for the previous decade with him in Canada. So, and obviously we did publish a previous CPG that covered all these aspects previously, but it was specific to the Canadian context, and it was specific to also return to work in this case.
Mhm.
So that's why we wanted to update this. And the other main issue in terms of this, we wanted this to be an international guideline, as you had mentioned. So we invited obviously Laurie to be part of this, and a bunch of other international collaborators to work on this on this current CPG that's just been published in JOSPT.
So this was a massive undertaking. You had 14 named authors from several countries. You had physical therapists, you had physicians. You also had patients involved in
Right.
this. Were there patients involved previously in those clinical practice guidelines, or was this a new addition?
So the interesting thing about the current CPG is the fact that we included more patient this time, and we actually included patient from Canada, from the US, and also from Ireland, where one of our co-author, Carrie McCreesh, does her research. So she's based in Limerick, and previously we had some patient. Partner engagement in the previous CPG, but this time we went around doing like a bit more work in terms of making sure that everything that we're putting out there in this CPG was acceptable and was fully readily understandable for patient too, in terms of of treatment options and so on and so on.
Great. So
And to
how,
add, and to
oh,
add
please.
to that, I also thanking the APTA, I did a clinical practice guideline on glenohumeral osteoarthritis, and part of their approach for their development of CPGs is to have patient review of the guidelines and being able to talk about each one of the recommendations. Do we think that there needs to be rewording? Is it clear, etc.? And so we kind of brought that forward to this to see if we could do, as Francois suggested, a little bit more in-depth understanding about the patient perspective.
That's great. I think that adds so much to the CPGs. Having that important or that importance of having the patient perspective is so important. So we talked a little bit about this has been kind of a long-standing kind of idea within the Canadians. How did you coordinate all of this with what you decided to focus on in these CPGs? So you had talked about, Francois, full thickness rotator cuff tendinopathy, which has been in previous CPGs. It is not in this CPG. So how did the authors go about kind of deciding where to focus and where to put all of your efforts?
And achieving consensus, because
Right.
like I have 4 kids and we can't decide on what to have for dinner. So I'm not sure how you got 14 different authors from different countries
Correct.
to achieve consensus on
Correct.
some of this. So I'm curious how you manage that.
So the previous work was quite an endeavor, and was at times tedious to come up with consensus with the Canadian versions of the CPGs. So we had talked with our international collaborator, obviously Laurie and Karen and other people involved in this current CPG, and we wanted something that was more manageable in terms and more practical in terms of publication and being able to reach out to clinician in terms of that. So that's one of the main reason we sort of narrowed down the scope of this practice guideline. It's still very relevant, but if you look at the overall CPG, there are dozens of recommendations to care for rotator cuff tendinopathy, and then in previous CPG we had double that amount of recommendation, and we felt that it wasn't, in terms of knowledge translation strategies, that it was sort of difficult to bring this all to clinicians and to other stakeholders. So that's one of the main reasons we wanted to sort of narrow down the scope, and it's still very relevant, and I think we've come up with something that's very, very useful to clinicians and to other people involved in treating rotator cuff tendinopathy. So
Absolutely.
Yeah, so before we get into the details of the content, I wanted to talk a little bit about what I think is important. And again, I'm reminded my oldest son has told me, Mom, just because you think it's important and interesting doesn't mean everybody else does. But I'm hoping you will find this both important and interesting, and that is a change in the grading scale. So the previous CPG had like A, B, B minus, C, not applicable.
Right.
Here, the grading system goes from A to F. Now, I don't know about F. I know. I don't know about you in Canada, but here, if you get a grade of F, like that's just not a great thing. So we have a little multiple choice question, hoping our listeners will pay close attention.
Exactly.
And maybe one of you can pick the answer. So the question is, the grading of the recommendations goes from A to F. What does a grade of F mean? A, foundational science. The recommendation is based upon biologic plausibility. B, funny you should ask me. It's based on expert opinion.
You found it humorous?
C, failed. We failed to find any evidence of it being effective. Or D, forget this one. It should be in the trash bin.
Okay.
So who knows what the grade of F stands for? The correct answer is
There's actually two answers to this.
I was just going to say, A and
busted.
B.
Busted.
Okay.
Well,
Well, no,
bring it on.
yeah, like this is something my students would come up and say, actually,
Yes,
there's two answers to this.
exactly. Oh my God.
Yes.
All right. So
Go ahead, Francois.
There's the official answer is that it's based on consensus from experts,
Right.
but at the same time, most often it was based on consensus because we couldn't find any evidence to
Right.
support that sort of
correct.
recommendation. So it's a multiple answer that we need to
So, I
to
love
log
that.
in here.
But that brings up a really good point of scouring the research and not finding data and then coming up with expert opinion. Would you agree with that, Lori?
Yes, yes. And we, in any clinical practice guideline, you think about, I'm going to summarize the evidence and say this is what should be kind of what you should be thinking about when you first see a patient with this disorder to consider for diagnosis, management, prognosis, return to sport, for example. But obviously, the evidence doesn't provide answers to everything.
Right.
So it's really short-sighted to provide a clinical practice guideline that only speaks to here's what the evidence says. And if there's no evidence, I'm just hoping you'll be able to figure this out yourself and good luck. See you later. Like that really just doesn't sit well with, I think, most people creating CPGs and also for clinicians and patients who are reading this. And you think about, you go to see a provider and you say, so what should we do with, if in this example, shoulder pain? Well, the evidence says X, Y, and Z. Well, I have a question about this. Well, we don't have much evidence about that, but I'll tell you, here's why this might be a good idea. So back to the theoretical foundation, expert opinion that really helps to inform and fill out, I think, about the guideline.
So along those lines, if you identified things where we didn't have robust research, is that a recommendation moving forward for researchers to look at to kind of establish more research in those areas?
I think if I was a researcher, oh wait, I am, I would use that as a recipe for here's what is needed. Here's the things that we're lacking. Here's the gaps in the literature. It's really a nice recipe for that.
Perfect. Thank
Yeah.
you for adding that. I agree. I think that's very helpful.
Yeah.
I think sometimes students get frustrated and they say, oh my gosh, there's no evidence behind this. And then I usually like to say, give it 5 years, stay tuned because every year we're digging and digging more information. So thanks for that.
Right. Well, and I see sometimes clinicians who are unaware or unwilling to acknowledge the other two legs of the three-legged
stool.
evidence-based medicine stool,
Yep.
say, well, the research says this, so I cannot do this, which sort of brings us to the expansion of the level of obligation, which I
Right.
love. The previous one had the positive side of the scale: must, should, may, which may I love as a middle child.
Mhm.
Like,
Yeah.
you know, I can go either way, maybe yes, maybe no today, whatever. But your new ones not only include the negative side of should not and must not, but you also define those, and they're not defined the same for every grade. I didn't see that though. When I looked back, and I fully admit I didn't go back like 10 years, but I looked back the past few years and I didn't see those terms defined previously.
Right. So on table 4 in the CPG, there's this magical list, and Francois is shaking his head, yes, and Lori is too.
Lori is too.
So we're really
Bring it on.
We're really curious
Bring it
how this came to fruition and how this came about.
Well, it's pretty simple actually, because we know from the get-go we wanted this to be we reached out to JOSPT, APTA, AOPT, and we wanted this to be a clinical practice guideline that would be endorsed, that would be supported by these entities. And JOSPT has this format that's already existing in terms of the level of obligation, and that's pretty much what we use, which is it's a very straightforward way of wording recommendation and the level of obligation to that. So we based it on that. Sometimes we did wonder how some recommendation would be worded with the level of evidence and the uncertainty that we had in some of these, but overall we came with this consensus, and all these recommendations are again are based on the consensus of our group, based on the most recent evidence, and in some case the consensus based on without any supporting evidence, because sometimes there are gaps in the literature for some of our recommendation. But coming back to that, I think that it's important to realize that it's sort of a golden age for MSK care right now. In terms of treatment, there are a lot of evidence to support what we're doing. And, previously we couldn't sometimes, come up with recommendation of high level, certainty, or having a level of obligation for clinicians to use such and such interventions. But we are now for a lot of what we're doing in physiotherapy or overall MSK care.
Great.
So you also include the terms use, perform, prescribe, or recommend, and I'm thinking that has to do with the International Flavor and Practice Acts and what we're allowed to do. I think, Lori, we're unable to do some things in the United States that people in other countries are able to do. Can you speak to that terminology of use, perform, prescribe, or recommend for those of us in the US?
We looked at it. Yeah, we had a lot of discussion about this because we had, as you know, a variety of practitioners on the CPG and thought about, all right, from a provider, what should you be able to do, prescribe, or use? And so we wanted to adopt that language so it was clear about how then, from the prior language that you talked about, should, must, then this is understanding, then how should you be using these?
Great. So one of the things that struck me was some of the pharmacology. And with corticosteroid injections, one of the things you had mentioned was recommend or administer. So are there countries where physios can do corticosteroid injections?
Yes.
Okay, so that's why that was written as such. So it kind of keeps people within their lane, if you will, or within their scope of practice for every country, adding to the international flair of this, but keeping it with the guidelines of how you need to practice within your country.
So are these guidelines, go ahead.
And being clear, I just feel like I need to add this caveat. I'm not aware of any providers in any country as a physio that you can do a corticosteroid injection without advanced practice training. So just to be clear that there's advanced practice training certificates in or licensure or acknowledgement, they're phrased different in different countries, to be able to provide that corticosteroid injection in particular I'm thinking of.
Thanks for that. That makes a lot of sense, and that's a good thing for our listeners to know.
Right, exactly.
Do you want to talk a little bit about outcomes and the plethora of patient-reported outcome measures?
So let's sort of dig into some of the content
Sure.
of the CPG. So in the first section, It is clinical assessment of the painful shoulder and suspected rotator cuff tendinopathy. And we know that the history and physical exam, the stuff that we assume to be fairly obvious and that we teach in PT school,
First level,
you
first semester.
teach it every day. That's all based on expert opinion because there's no RCTs or anything like that, or systematic reviews that show that it makes a difference if you do or don't do this.
And is that an across the board? And yeah, Lori,
Correct.
is that consistent in other CPGs that
There's
you've seen?
Yes, there's no evidence that says if you didn't do a assessment of shoulder range of motion, here's the poor outcome versus if you did do assessment. And so for the most part, for any kind of exam, beyond like the quote unquote special tests that we talk about later,
Mhm.
pretty much we can talk about, are they reliable tests or not? There's no evidence to say, if you didn't do this, the patient's not going to do well. So does that make sense?
Yeah,
Yep,
it does. And
perfect
it's
sense.
very interesting.
Perfect sense. But Jill asked me about outcomes. And so I've always been really interested in patient reported outcomes because actually, in my opinion, they're fraught with problems on multiple levels. But you have a list of about 10 patient reported outcomes that have psychometric properties that have been established. So, any thoughts on the use of those tools? I come from an institution where they often tell us which ones, one or two of them that we have to use to provide consistency across the institution. And
Even though it might not be the best for the patient.
right, exactly. So I'm wondering if the two of you have any thoughts on that use.
Do you want to go on that, Lori?
Sure. I'm on the other side of the fence, Lori. Sorry. I'm a strong advocate of use of outcome measures. And
Me too.
yeah, and Francois as well. That's true.
Well, let me clarify. I'm a strong proponent of the use of outcome measures, but using the right outcome tool for the right patient so that you're matching and you're not getting ceiling or floor effects because your institution has required you to use this outcome tool. That was my point. I am all in on
absolutely.
reported on outcome measures, especially
Sure.
patient reported.
And I think about the difficulty in a single tool doing everything for everyone
Right.
all the time. So
Right.
I am in part of my role at USC is I'm the director of clinical outcomes and research. What's that mean? I really help to guide what we think about, what we're going to collect, and what's the utility of that. And here's my perspective. I also see patients at the healthcare at our outpatient clinic as well. And I can't imagine seeing a patient without an outcome measure. I find them incredibly helpful to understand the patient's perspective. And I agree with you that they can be challenging to understand what I'm asking them and is that capturing what they're thinking about with regards to their shoulder pain, for example. So I think about the key thing of triangulation of outcomes. I think about a standard outcome form that asks 20 questions about function and pain. So it's cueing them about different things. Some of those things, I'm treating an 80-year-old with a full thickness tear and I'm asking about throwing the ball overhead. I mean, are they really interested? Well,
Right.
I'll have to tell you, I am surprised that I had an 80-year-old who had a full thickness rotator cuff tear in the clinic and said, that's important to me. I'm like, what? He goes, no, I have 3 grandchildren and I really want to be able to do that. So I think about using this as a standard thing to understand the spectrum of functional activities, for example. But then what's most important to them, I find we recommended like a patient specific. Tell me 3 things you can't do that you really want to do because of your
Right.
shoulder pain. That really focuses then. It's
Yes.
to me asking what's the goals of PT. To me,
Yes.
it makes
Right.
it easier. I give you the patient specific scale and they tell me, here's the 3 things and here's the difficulty. And I'm like, well, shouldn't that be what I'm focusing? Isn't that the patient goals?
Yeah,
Absolutely.
I'm all in on that. I'm all in on that.
And the third thing I think I find complex though, and I think about this in my research, but it really translates to my clinical practice. When I'm seeing a patient, they top out. They have a ceiling effect on the pen
Yes.
shoulder
Mhm.
score. They have a ceiling effect on the patient specific scale. And you go, all right, well, why are you still having problems? It has enables me to have a dialogue with the patient about why then, when I ask you the third question, if left the way you are today, 6 months from now, would you be satisfied? A past question like patient acceptable symptom state. And they say no. I'm like, well, why not? It allows me to understand a dialogue of what else are they needing, and do they still need to be in physical therapy or not? Or do they need another provider? Well, I'm still really fearful of using my shoulder. I can do everything. Oh, all right. I need to pivot here and provide a different aspect of care. It's not about improving your function. It's about your psychological status that may be really impactful for not allowing you to return to the things that you want to do. So
Right.
I find them incredibly helpful and able to get at information pretty quickly.
I love that. And you know what I love about that is it allows you to have a dialogue with the patient. The issue that I see as a clinician is the institution that sends out a form to be signed electronically that ends up somewhere. We're not exactly always sure, but it's not part of the dialogue with the patient. So I know, for example, my son who had hip surgery, every 6 months he gets these forms online and he rolls his eyes and goes click, 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 click. So I think how that
Right.
patient reported outcome measure is administered is critical. And I love that you hit on that.
Well, and I love the whole concept of the ceiling effect and
Mhm.
talking to them about why they have this perfect score and they're still having problems. You know, working in sports, we see that a lot. And that's so great to use as a springboard for that conversation. So, Francois, are patient-reported outcome measures commonly used in Canada? Is that
I think we've got the same issues that the states have, and
okay?
if you look elsewhere internationally, I mean, we always advocate for this. And obviously, I'm a researcher, but I'm also a clinician. I use them all the time with my patient. But I do agree that sometimes they might be difficult to use. They might not, for all the reasons that we've said before. Sometimes they might not apply totally to the patient, but I still think that they should be systematically used. And we had a recommendation about that they should always be used with the patient. And we gave we couldn't find one that was a lot better than the other. We have a list within the CPG, and I think if you look at these, like you can find the ones that you prefer as a clinician, that could potentially be more applicable to some of your patient with tendinopathy than others. So there's a list there, and I think people should systematically be using them, and that's important. And for all the reasons that we've said previously, I think it helps out figure out what's going on with the patient, and if sometimes they might have limitation to that, it is sort of a springboard that we can use to talk to the patient and figure out exactly why they're not happy with their shoulder and so on.
So I think that's a great point. So similar to you individualize somebody's rehab program, you need to pick an individualized patient-reported outcome measures. It's kind of part of that package. And I don't think people always think about it that way. And I really appreciate those points that you brought up.
Yeah. That was a really great discussion of
Absolutely.
the first section. So was there anything else in the first section on clinical assessment that's new or anything that surprised you that we should discuss before we move on to pharmacologic?
I think we're good. I think there's a lot more to dig in if people are interested and they need to go back because we've got several recommendations,
Right.
regarding yellow flags and obviously assessing potential red flags and so on and so on. But there's good information for clinicians to in this CPG to help them out be more systematic and more evidence based in terms of assessing shoulder pain and patient with potentially radicuff tendinopathy.
Great.
Well, it's 40 pages. We can't go into every one, Francois. Unless you have a couple more hours for us.
But it's there for the reading.
Yeah, it's there for your reading. Small chunks, do a little bit at a time.
Right.
So let's move on to pharmacology.
Pharmacology. So I like how you divided it into kind of the lowest hanging fruit of oral medication versus the next level, which is the invasive injections. So it looks to me like pharmacology, from a pharmacological perspective, acetaminophen may be recommended, but with oral.
Grade C.
I know, But with oral NSAIDs, there was very limited evidence on its efficacy with no long-term studies on the risks and benefits. So what if taking that information, you both see patients, how do you explain that to your patients when your patients say, should I be taking some sort of pill? What do you say to them? How do you interpret that and how do you explain that to them?
Well, the recommendations are there. There is a bit of data to support the use of such medication, at least in the
Mhm.
short term, if you look at NSAIDs, for
Right.
example. So
Yep.
there are data, there are specific, randomized control trials that have looked, at the effects of oral NSAID to treat shoulder pain. And, the level of evidence is not of the greatest, but it is still there. And in the short term, it's something that we can use with patients. And I use it all the time with all my patients that come up to me with potential shoulder rotator cuff tendinopathy. The answer is no. But sometimes if they've got more important pain and they've got limitation and stuff like that, it's certainly something I discuss with them. And if you look at the overall evidence, for short term, obviously we need to account for the potential side effects of oral NSAIDs because there are. But at the same time, if you're using it in a short bout, short term, the literature is looks pretty good in terms of that there are very limited potential side effects of using it. In terms of tendon health and stuff like that, I think we need to consider this if it's more of a chronic use of oral NSAIDs.
Mhm.
You could see potential benefit, deleterious effects on tendon health and stuff like that with what all NSAID. So that's why we had this. So we've got this level of evidence, and also for you just using basic acetaminophen. So that's sort of fine in terms of, and that's based on indirect evidence. So there are no
Mhm.
real trial looking at
Right.
Right.
specifically at that, but for general MSK pain, we know that it can be useful. There are several systematic reviews that have shown benefits of using that.
So it comes to that clinical decision making and the return on your investment. Go ahead, Lori.
Yep. I just think if I had a patient in front of me today and they came in and they had very little pain and they
Mhm.
were having difficulty raising their arm and they asked me about taking medication, if pain is a limiting factor that really is driving your reduced ability to sleep at night, to get some good rest, because we know sleep is a critical component to recovery. If you're having so much pain that you're having difficulty raising your arm, using your arm for daily activities, and we know that moving your arm frequently is helpful in restoring recovery or recovery as well. So I'd explain that and say, if you had very little pain, I don't know how much of a benefit you'll see from taking some medication. So I'd suggest that you not consider it at this time. Let's see how you do for a couple weeks with exercise, and then we can revisit that, or shorter term if you want to revisit. But if somebody comes in with a lot of pain, I would say, have you considered
Mhm.
taking and
Mhm.
walk through the options and say, there is some downside of taking this longer term. So we're thinking about this in the short term, and evidence indicates that it can be helpful in the short term, but we're not talking long term. And I'd emphasize that long term piece, that chronic use is not something, this is not going to be something you'll be using for a long time.
So
And when I say a
Lori,
long time, I'd clarify short term, like less than a month. And hopefully that, yeah,
that's great.
So you're talking about these over-the-counter medications,
correct.
and do you request that your patient discuss it with their physician or their pharmacist before taking this, or do you leave it at this is what the evidence says and this is what I can tell you? Where's that fine line?
Yep, that is a fine line, and that's how I would phrase it with, listen, here's what we know, and this may be helpful with your pain. That's a decision for you to make. If you feel like you need more information, want to discuss that with your physician, feel free, or you can ask a pharmacist when you go to purchase this somewhere, and then I'd leave it at that. But I would not be saying you should or should not, meaning I'm not prescribing it because that's outside my scope of practice, but it's an over the counter, so I can give them the information and let them sort out.
Thanks for parsing that fine line for
That's-
us.
that-
Like,
that's-
I didn't want to have to do that.
Right. No, and I think that's very important. It's very important for our listeners to hear.
Yeah.
So should we move along a little bit and talk a little bit more about interventions, education, exercise?
Right.
Exercise is the mainstay of, I think,
Right.
almost any
Yeah,
good
that's what
rehab
people
program.
are going to want to also know about.
Sure.
So, yeah, education. Great to see. Great to see. I mean, I don't know about you, but our parents were not happy if we came home with a C. So why does education, which seems like, and if you look at the guided clinical practice in physical therapy, like education is a big piece of physical therapy care.
Mhm.
So can you talk a little bit more about why the C?
I guess I can do that. So I mean we're basing our CPG on direct evidence,
Right.
synthesis. So if you look at the overall literature right now, it's difficult to find randomized controlled trials, for example, that have specifically isolated the effect of education, which is might be surprising to a lot of people, but this is actually true. So we don't have, very good evidence, especially for radiculopathy, like showing the specific effect of education, because most of the time the trials will have like a multi-component intervention, including education. And if you look at other type of MSK disorder, and there is very good evidence showing that if you give active education to patient, it can improve the outcomes of the patient. But in the case of radical tendinopathy, not a lot of data out there, so that's why it's a great C. But I think I need to stress out, and Laurie will agree with me on this, that like specific active patient-centered education for leukotenopathy is part of the cornerstone of intervention that we need to do with patient with exercise. So it needs to be there. It needs to be systematic, and it can't just be just like a leaflet, or just like something
Right.
that you go very very quickly with your patient. Oh, by the way, like even though there's pain, there's structural damage is minimal, and so on and so on. And if you can move, if you can manage your pain, we want you to move, and so on and so on. And we can go into the details of what exactly education should be, but it needs to be systematic with our patient. And personally, I don't think, at least in Canada, and I think in the States it's a bit like that. I don't think that we're doing such a great job of doing that systematically with patient with MSK care. We always say it's important, but exactly what is important, what are the active components of education? This needs to be further, evaluated, and we need to train our physios a lot better at doing that systematically, and doing this in a very patient-centered way. So, but yeah, so great C, but it needs to be there. And if you look between the lines of our
Right.
CPG, we find this very important, and we advocate for more of that in terms of overall training, overall intervention with our patients. Yeah.
And Lori's shaking her head
Vigorously.
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 So she
Yeah.
definitely has.
Yeah, I like that. I heard 3 times systematic patient education. I really like that bottom line up front. We walk in the States, Francois, it's exactly the same way. And what I see in mentoring students, mentoring residents in the clinic, that the patient education is a piece, but it's not delivered systematically to hit all the bullets that you really should be hitting. And it's sometimes like a sidebar, like my exercise is really what I want to do. My manual therapy, that's really what I do. Oh, and by the way, did I ask you about how you're sleeping? Did I ask you about nutrition? Did I ask you what you want to know about your condition? Do you understand the prognosis? I'm really sometimes surprised that the lack of not providing a prognosis to the patient. Look, I've seen lots of patients who look like you, and the evidence indicates that you'll do well with therapy. And I expect that we'll be seeing each other for maybe 6, 8 weeks, and I'll be reassessing you as we move through to make sure that you may get better faster, and we may not see each other as long as I project at this point. Like, patients want to know that, and I'm surprised at the lack of providing that to the patient in a systematic way. Sorry, that plug is just, yeah. And I think of a paper, a randomized clinical trial that Francois and Jean-Sébastien Roy have done with Marc Dubé, that patient education versus two other forms of exercise. And, there's no difference. Patient education is very helpful to patients. And sometimes that may be all they need.
So it's so great that you say that. And I appreciate, Lori, I'm just kind of chuckling because when we do our practical exams with our DPT students, one of the things we give them points for is the diagnosis and prognosis statements. And those poor PT students, they know they want to give a prognosis, but because of lack of experience, they're like, you're going to get better. And after I'm out of my clinical, I'll be able to tell you how quickly, but right now I can't. But we're training them to do that because I think it's so important. So I love the fact that you hit that, and the systematically portion of it is really good.
And you have to give them some estimate of what you think.
Yes.
You cannot say, oh, just go schedule and I'll see you for 2 times a week for the rest of your life. I mean,
Right.
you have to give them some understanding about how long this is going to last. And you may not, as an early therapist, feel comfortable
Right.
realizing that the evidence is vague and sometimes not really well defined, but you have to give them something for them to help them understand how this course is going to go. I think about the anxiety of not knowing contributes to their expression of pain that they're having.
That's such a good
Yeah,
point.
that's
a really good point.
I love that. And I feel like some of the pressure comes from external forces where we're scheduling patients like this, and then I can't get you back in for another 3 weeks. And so here, try this and let me know if it's not working. I think some of the time crunch with medicine today is really impacting those things that you just mentioned that are so critical for success, for patient outcomes. Yeah, you really nailed it. And Francois, I like that you mentioned between the lines. And I know it's 40 pages, but if you digest a little bit at a time, there's so much here that's rich for you to dig into. So
I agree.
yeah, go ahead. So
Should we
And
talk
I
about
think we've one thing that's interesting about our CPG, and Laurie will agree with me on this, is that we're offering also patient recommendation, and we've actually got management algorithms for this condition. So there's sort of a hierarchy that's built into our CPG in terms of, well, you should be doing this first, and then you should be doing this first. You should not be doing this, and if patient doesn't do better, then you can consider such and such intervention. So that's interesting, and that's very helpful for clinician. Not all CPGs have got that, but I think that's sort of the strength of the one that we've just published, actually. So yeah.
Agreed. If not after 12 weeks, if they're not improving, you need to do this. I think that's really helpful. And I think it gets to Lori's statement about prognosis and helping those young clinicians kind of determine prognosis.
Yep.
Should we talk about sports?
Yeah, return to sports. That's new this time.
New, right? So, Lori, I think this is probably a passion of yours, is my guess. Yeah. You want to talk about it?
Sure. We, Ellen Shanley on the guidelines headed up this section for us. When we were working on this, Francois had the job of wrangling all of us and
Just 3 teenagers. I'm sure he had a lot of experience, right?
It was a bit better than with 3 teenagers, I can tell you that. And I'll be positive here.
We
I'm
listened.
joking. I'm joking.
And we kind of all took different aspects of kind of helping to guide those, etc. But anyway, back to the sports. We really wanted to add this in there from the last CPG, even though it can dovetail quite nicely with the return to work, in the sense of work can be a sport with respect to loading to the shoulder. And so we talked about what was known with return to sport and what can potentially use to guide that return to sport. But there's not a lot out there with respect to exactly what a specific test or measure that could be used. But we walked through some of the performance and some of the things that may be considered for assessing return to sport.
which is great. It's very helpful because there's really nothing else out there looking at that. And so from a person who works in sports, I found that part very helpful.
Mhm.
Scratching the surface.
Yeah. So, kind of leading into a little bit of a wrap up here, would either of you like to comment on the recent JOSPT publication titled What's in a Name? The case for rotator cuff related shoulder pain and clinical practice by Jeremy Lewis, Paul Minkin, and Amy McDevitt?
Laurie, go ahead. I haven't read the full paper. I know Jeremy. I know his position on rotator cuff related
Yeah,
shoulder pain, and I'm happy to comment after you've done it. I think you might have read it, but I haven't yet. So it's on my list.
yeah. It's a commentary editorial, one of those. I
Yep.
can't remember. And basically, it's the same that Francois and I've talked about this before and know that position. Um, I think rotator cuff is like patellofemoral pain. What do we call this? And bottom line up front, do we know that the tendon is always the source of pain? No. So the argument from the groups that argue for not naming it a pathology, but naming it this rotator cuff related shoulder pain is the argument. Definitely not going down the path of calling it subacromial impingement, because we now know that impingement is but one mechanism that can be leading to this rotator cuff tendinopathy, full thickness tear, rotator cuff related shoulder pain, whatever you'd like to call it in that phrase. And there can be posterior superior impingement. And from more recent modeling studies, we know that posterior superior impingement can be occurring much more frequently than we believed before, and not necessarily just in overhead athletes. This posterior superior impingement can be occurring in flexion, scaption range of motion at about 125 degrees. That's what all of us do, not just overhead throwers. And the subacromial impingement likely isn't occurring once we get above about 70 degrees, because the tendon is no longer under this subacromial space or under the subacromial arch. And so loading is another mechanism, tensile loading to the tendon. So given that we have all these different mechanisms that can be influencing the development of this rotator cuff tendinopathy, calling it the mechanism is a bad thing, because which one is it, or is it the combination of? All right, so we've gotten mechanism out of the way. So now we say, should we call it rotator cuff related shoulder pain? Here's why I advocate that a pathology. I think about delivering the message to the patient who is sitting in front of us, who is also maybe interfaced with a provider outside of physical therapy. And in all of the providers that I work with that are orthopedic surgeons, primary care, they are not recognizing this vague term of rotator cuff related shoulder pain. And so to communicate across the healthcare system, I think using the terminology, and do I think people might argue that calling it something means, oh, they're going to think they need surgery or not. I don't think rotator cuff related shoulder pain versus tendinopathy, and Francois agrees with me, is going to drive people to think surgery versus not in that terminology. And finally, I think that differentiating between tendinopathy and a full thickness tear is a prognostic difference, and two, is a driving towards a potentially different treatment. Tendinopathy is not a surgical intervention for the most part, and a full thickness tear, a surgeon may think surgery. How I'm explaining to the patient, oh, is therapy going to help my full thickness tear heal? Well, no, it's not. But here's the good news. Lots of people get better with rehabilitation and are not symptomatic. So again, I think it's important to differentiate the pathology, and the rotator cuff tendinopathy, full thickness tear is what I lean towards, and not the other term.
Awesome. Thank you for that. That was
great.
that was a great detailed explanation.
And
So
the other thing is that for shoulder, having a anatomical diagnosis is still relevant for treatment plan and orientation. Like Laurie said, if it's tendinopathy versus a full thickness tear, prognosis might be different. Treatment plan and prioritizing certain types of treatment are going to be a bit different if you look at the evidence. And going back to our previous CPGs, we show that. And for other shoulder pain disorder, obviously, like for example, capsulitis, like the evidence, is clear in terms of if you've got capsulitis, that injection should be something that you consider from the get-go, which
Right.
is not the
Right.
case, which is not the
Right.
case for rheumatoid tendinopathy. So
Right.
I agree with Lori in terms of, calling it a tendinopathy and not calling related shoulder pain. And that's a bit different at the shoulder. If you look at other, regions, I'm fine with, having these broader terms used for non-specific low back pain and for patellofemoral
Right.
syndrome
Right.
and so
Yep.
on and so on. But I think the shoulder is something in itself that we need to consider being more specific in terms of the diagnosis here, it'll impact prognosis. It changes the prognosis and it changes the type of treatment we offer to these patients.
Right.
Awesome.
Great.
So let's close with what you're working on next. Francois, do you want to give us a quick rundown of what's next in your world?
Well,
Oh,
if it's already been published and we should be already talking about updating it, because there's a lot of literature coming out, so we're probably going to be working on trying to get funding to supporting updating this eventually. I
I
just
love
want to
it.
say, the work that we've done, and you've alluded to that, and it's a massive endeavor, and it it,
Mhm.
it 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 costs a lot of money to do that, and to do that
Right.
in a very efficient way, and to do something that's useful for clinician. It's hard to do, but someone's got to do it, and we've done it, and we're probably happy to do it again, Lori. We'll go forward and update it. Yeah.
Hmm,
Oh, he's got her
Right,
right
exactly.
there. It's
think
been
about that.
recorded. Record. You've been
Yeah.
recorded.
Joking.
And
Absolutely.
yes, and we've collected a whole bunch of data related to full thickness rotator cuff there. So we're digging into this and trying to see if we're going to go forward doing like a separate CPG for that
I
too. So
can't wait.
Great. Yeah. And Lori, what are you working on?
Right now, research wise, I have focused, as you described in the beginning, on understanding why people develop this pain and what could be other drivers besides just biomechanics and the physical impairments that we're assessing. We have a paper review about psychological factors, and what I find really intriguing is how they, in some people, change over time over the course of the rehabilitation, and other people they're not changing, like
Hmm.
pain
Wow.
catastrophizing.
Wow.
They come in with a bit elevation, but some people, therapy really, they help reduce that pain catastrophizing just through exercise, and some not overly systematic patient education, and other patients aren't, they become more so almost, and that makes sense.
Wow.
Come in, you give me some exercise, it's not helping me. I'm like starting to panic, like, oh no, why is this not helping? And so it's helping us to understand how we can identify these people earlier and get them into a stepped rehabilitation program that puts them into the right treatment for the right patient. And the other piece I find intriguing that we're working on is understanding what's happening at the brain level, which
Mm.
can help to drive maybe these patients who are non-responders to exercise. Like, why are people responding to exercise and patient education, and then why are some people not, and what's driving that from a central nervous system level?
So they have a lot of free
Really?
time. They have a lot of free time, sounds like.
and it
We are.
comes back to and it comes back to
Yeah.
education to patients. So
Right.
it's very much an area of research that needs to be that we need to go into. And Jean Sebastien and I and Lori, we're all doing that right now because I think that's super important. And just to
Right.
finish, I'd just like to acknowledge, like the whole CPG. I don't think we've mentioned this, but this was such a great team effort to come
Mhm.
up with this CPG. And Jean Sebastien could not be here, but I'd just like to acknowledge everyone else that's been
Mhm.
involved into this and the co-authors of this, because we could not have done it without them. And obviously, with my expertise and educating three teams was quite useful sometimes. But overall, I'm joking. Obviously, it was a very long but very smooth process with our team to come up with this, and I think it shows with the quality of the work that we've
It's
done.
amazing.
Yeah, team
Love
members
it.
make a huge difference. So
Exactly.
you chose well. So well, thank you again to both of you for
Yes.
for the CPG, for the work that you're doing to advance the profession, and for spending this time with us today. It's been great.
It's been a great discussion, and I think our listeners
Yeah.
will really appreciate it. So thank
Yeah.
you for all you do, both of you, to
Yep.
move our profession forward. We're greatly thankful.